Good afternoon, everybody. I'm Steve DeMello. I'm Director of Healthcare here at CITRIS. I'd like to welcome you all today to our research exchange. Also our web viewers who are part of the webcast activity. Remind you that for folks who are interested in our series on energy, the I for Energy speaker series is every Friday at noon, also here. And also remind you that everything you have for lunch can go in compost except aluminum if it's used and plastic bottles. For folks that are involved in healthcare IT, Kaiser Permanente is somewhat of a gold standard. At a time when most of the people in the industry and the federal government is encouraging baseline use and really initiation of electronic health records, Kaiser has a long and successful history of having developed and launched a records platform and is at the point of doing a number of very interesting and innovative things building off of that platform. One of the people who's most responsible for that innovation and development is our speaker today, Chow. Yan is the director of Kaiser Permanente Information Technologies Innovative and Advanced Technology Group and works to identify new and emerging clinical information technologies that will impact healthcare in the next 2 to 5 years. Yan has had a successful clinical practice at Kaiser Permanente over 2 decades. For 10 of those years, he's also been involved in regional IT management, overseeing a number of their operational systems, including enterprise email, reference databases, the CIPS system, which is the one that's primarily used among the 58,000 providers, and 60 dispersed sites to manage schedules, lab work, radiology, medications, and immunizations. Yan earned his AB with honors from Harvard University, his medical degree from the University of California at San Diego, and in 2005 he became a glorious California alumni with graduation from the Haas School of Business where he was valedictorian. Please join me in welcoming Dr. Yan Chow.
Thanks, Steve. Thanks for having me. It's a great day outside. I'm just amazed you guys are in here. This is really good. I work for Kaiser Permanente, and so what I need to do probably is to start to introduce you to Kaiser Permanente a little bit if you don't know. Our mission basically is to provide affordable, high-quality health care services to improve the health of our members and the communities we serve. And we are the nation's largest nonprofit health plan with an integrated care delivery system, which is very important in terms of our structure. Almost 9 million patients, 14,600 physicians, or 14,600 CEOs, 170,000 employees, 36 medical centers, over 400 medical offices, and about 37 million office visits per year. We have 110,000 biobank DNA samples from our DNA project, over 3,000 research and evaluation studies, over 700 peer-reviewed published studies, and revenues of about $40 billion. Our IT budget alone is about $3.3 billion. A lot of that is our medical record. We have the largest, most advanced EHR, electronic health record deployment in the world, and our PHR, which is a patient health record, is used by over 3 million patients. So I'm going to talk a little bit about innovation and how it sort of came about at Kaiser. Of course, Kaiser's always been innovative, but in a structured way for health IT, I'd like to talk a little bit about our organization. In terms of innovation, you can think of innovation as the introduction of something new, a new idea, method, or device, an idea new to healthcare, or an idea new to my healthcare organization. And all those definitions apply, actually, when we talk about innovation at Kaiser. I love 2 quotes by Wayne Gretsky. I don't know, do you guys know who Wayne Gretsky is? The great Wayne Gretsky, ice hockey player, is probably one of the best of all time. Somebody asked him, what does it take to be a great ice hockey player? And he said, a good player plays where the puck is. A great player plays where the puck is going to be. And of course, the question is, how you can tell where is the puck going to be? And he also said something else that was very interesting and I thought very insightful. You miss 100% of the shots that you don't take. So I think that sort of frames the innovation discussion. And in terms of macro trends in medicine today, I'm just going to give a very high level in terms of what we're looking at and most people in the United States. Healthcare costs are rising twice the rate of GDP. As you know, insurance premiums, or you may know, insurance premiums are outpacing both inflation and pay. There are about 78 million baby boomers, those folks born between 1946 and 1964, coming to the market for healthcare services, and about 50% of our expenditure is actually spent on only 5% of the population for chronic diseases like depression, diabetes, congestive heart failure, and hypertension. Health reform, just recently enacted, will add another 49 million uninsured Americans, and the per-member reimbursement is likely to decrease. 40% more family practitioners needed by 2020. But if you look at internal medicine residency programs, how many folks are going to end up in primary care? 2%. That means when you grow up and you want a doctor, you may not get one. That's a serious shortage. Healthcare workers tend to be older. 50% of nurses plan to retire in the next 10 years. And by the way, 50 to 70% of lab techs tend to retire in the next 10 years, want to retire in the next 10 years. So training highly skilled practitioners takes years. And the pace of technology change is not getting slower, it's getting faster. And today what we see is that not only is it health IT faster, but a lot of different technology areas are also changing very fast, and they're all sort of impinging on health IT, I think partly because all the money is going to health IT. So a lot of this stuff is impacting health IT. And so a couple of years ago when we started our group, we sort of thought about what will it take to really get a sense of where innovation is coming from, what we need to pay attention to, and what we can ignore, and sort of in order not to get blindsided. So looking at the types of innovation that we see, one is the incremental innovation, and some of you guys may know this. This is small, but a significant improvement in existing services, sort of what we call best practices. There's a breakthrough, which is where existing technology goes into a new market, but new technology goes to an existing market. And finally, what we're really interested in is a disruptive, game-changing innovation, which is where it disrupts the entire market or it creates a brand new market. What is the nature of innovation? The first question people ask when you work at a big organization, what is the ROI? And for us, ROI it comes in 4 categories. One is quality of care, one is service level, cost savings, and professional satisfaction. Those are sort of the 4 points of our compass, our value compass. So as you see on the curve, we try to maximize it over time. But the big question for innovation is there a way to change the curve? Is there a way to create a new curve? And I think that's sort of the underlying assumption behind innovation as a strategy. And if you think about, here's another way to think about it. There are 2 axes here. One is the care model disruption. On this axis, the vertical axis is technology disruption. If you look at the first quadrant, incremental technology for old care model, best practices is what we call it. If you use technology that's disruptive, but you put it in an old care model, it's called workflow acceleration. If you actually re-engineer the care model to be a new care model, and you use the same technology, it's called workflow re-engineering. But really, what we're looking at is game-changing, where you put disruptive technology into a new care model. And you can imagine in healthcare, and I'll talk a little bit about the factors later, that this is probably the hardest thing to do in healthcare. It's the highest risk, but it's also potentially the highest reward. Where do we get innovation from at Kaiser? Internal groups and individuals, disruptive technologies from startups, new products. I actually had people bring in things that were wrapped in duct tape, and they told me, don't drop it because that's the only one I got. Versus big companies like Cisco and Intel coming out with new products. A lot of innovation out there in the healthcare market. We also source innovation from academic and research institutions like UC Berkeley, government, military institutions, technologies from outside healthcare. Very, very important source. Because many of the things that you see outside healthcare, through consumers, will actually enter healthcare. Of course, the classic is the iPhone. Some questions we ask, people always ask, how do you guys vet your vendors that come to you? We've actually looked at over 700 vendors in the last 3 or 4 years. We ask, what problem does it solve? And although this seems kind of obvious, seems sometimes not that obvious to vendors. What problem does it solve? Is there a demand for it? Does a new technology fit Kaiser Permanente? It may not fit our model of care. Will management support it? Does it confer a strategic advantage? And that's something we're actually working on today is how do you make innovation really a strategic advantage in healthcare, which has not been a traditional strategic advantage? How might we pursue it? What would it take? Is there a clear definition of success? And that's really, you need to know that before you get into anything. What is the time frame for that? What are the industry trends? What is the technology, the pricing model? This is kind of reminds me of my business school days. When you think about the business plans, it's very similar to that, but it's a customer-focused business plan. How strong is the vendor? How many rounds of financing? You know, what are they living on? What is the vendor's roadmap? Where are the gaps? What is the competitive landscape? Oh, by the way, when we see vendors, you might wonder, what is the win-win trade-off for them and for us? The win for us is that we get to see very early technology, and we've actually, over the last 3 years, developed pipelines to investors and startups and so on. The win for them is that they get to ask an enterprise person what's missing. And I think that's very hard to do in healthcare. If you think, how would a startup actually get into a hospital and ask somebody, what's missing in my product that would make it better for healthcare? That's very hard to do that, very hard to get entry. What should the recommendation be, and what other factors? Well, consider the organization. Here's a cartoon that says, I'll be happy to give you innovative thinking. What are the guidelines? What is the leadership vision? That's probably one of the most important factors. Our group was started by 3 visionary leaders, and if they hadn't been there, I don't think we would have an innovation group at Kaiser, even though we're very innovative as an organization. It takes that leadership at the top to really push it. Because innovation doesn't fit anywhere else, so it has to relate to the top. Core process, is it part of the organization? Where is its home? What metrics are people using to measure it? What is the governance? How do you resolve? As we often see, we see 2 or 3 projects that are incompatible. Who decides which one should go forward? If you don't have anybody deciding that, you kind of wonder, maybe innovation is not really in the structure. The silos, you guys know about incentives to innovate. Voice of the customer, very important as a guideline for success. And just how aware is the organization of industry trends? Consider the industry. Some of you guys are new to healthcare, some are not. You know, healthcare is a very heavily regulated industry. Some people have called it 12 industries in one. Very high aversity to risk. The level of competitive pressure varies. In Southern California, Kaiser Permanente actually is doing very well. So the level of competitive pressure is lower, which means there's less incentive to innovate. In other regions, we have a much harder time, so we have greater incentive to innovate. So it's kind of interesting. We do have a innovation learning network that we share with other organizations, including the VA and several other big providers. So we do share innovation. We are a nonprofit. We have a sort of a community benefit function. But here's a cartoon that says, congratulate me. We've crafted a privacy policy that meets every single regulation out there, and everybody's walking around naked. So it's sort of the only way to meet all those things. Now, consider management style. Do you have a command and control management? Do you have consensus management? Are they open to new ideas? Ability to accept change, and especially in healthcare, permission to fail. You know, doctors are trained in medicine to never fail. And that's a tough barrier to get through, to say, you know, try this and see if it works. That's just not the way they work, not the way they're trained. Is there time for free thinking, or do you insist on long written reports? And I just wanted to throw in a technology I saw recently, which is interesting. This is the equivalent of the 1970s mood ring. You guys know about the mood rings? They used to wear them and show you what the mood is. Well, this is a pendant that uses conductive ink and fabric sensors to tell the mood of the person who's wearing it. So you could actually put it on your boss before you ask for a raise and that kind of stuff. Very good technology. Consider the accountant. They usually look at things as a short-term focus. Their financial projections and plans usually don't include innovation, and they don't know how to value innovation. So when you can't value innovation, you can't figure out what is the return. You know, why should we invest? Where does the budget belong? Is the payback period too long? I think that these are questions that you probably are sort of like common sense, but it bears thinking about. Innovation is about the future. And so there's 2 things. One is that it's long-term, strategic. The second thing is there's no track record. Those 2 things will kill you with a CFO. So having a very visionary CFO and finance director is really important. Consider the individual. Here's a cartoon. It's this poor little guy. He's sitting under the seat there. Fear of change, fear of failure, fear of humiliation. Here's one that's, I think and I used to be in some startups, and this is, somebody might copy the idea, but you know what? That's not so important. What's the key between a successful startup and one that's not? It's the execution, not the idea. Much more the execution. Co-worker jealousy, lack of knowledge on how to innovate, stuck on past success, complacency. And probably the most common is indifference, apathy. So our group was formed in 2006, part of KPIT. We have a number of different folks in it, including physicians and nurses, project managers. In Kaiser, we have a parallel reporting structure, so I'm sort of the medical director. We also have an executive director, Faye Sahai, who's part of the IT organization. So she, on the nonprofit side, takes care of the sort of hiring, firing, the P&L stuff. I'm on the medical side. We have an Innovation Lab software development team that does a very fast cycle development for innovation projects. And what we do, how many guys have seen this Gartner Hype Cycle? Just raise your hand. This is from the Gartner firm, which is an analyst firm, a technology industry analyst. And their hype cycle, they looked at, and this is probably from 2 or 3 decades ago, they looked at how technology is hyped in society. And it goes through 5 different phases. One is, in the beginning, the technology sort of goes up the hype cycle, very visible, a lot of expectations over time. And that section is called the technology trigger. And that's when the technology starts to gain visibility and hype. Then it hits the peak, and Gartner calls it the peak of inflated expectations. That's when everybody's talking about it. The iPad is a perfect example. Everybody's talking about it. It's a peak. You can't get any higher in terms of hype. And then there's a trough of disillusionment. And that's when the technology just slides off that peak and plunges into a depth. When people start to realize, hey, it doesn't do what the hype says. It doesn't do that. And then after a amount of time in the trough of disillusionment, it starts to climb the slope of enlightenment, where people start to understand what is the technology good for, what is it not good for, and so on and so forth. And finally, you enter the plateau of productivity. And Gartner calls it this, but just understand that even when you're in the plateau, you're just beginning the mainstream adoption. This is very early. Mainstream adoption starts at 20 to 30% of the market. So really, this is just right at the beginning. All startups should look at this and think about it. So where's our focus? We look at stuff that's in the first 2 stages. This is actually Gartner's sort of broadest aggregate hype cycle. It's the hype cycle for emerging technologies 2010. And I'll show you some of the things that we looked at. But you can see that there's a lot of different things on this thing, and they're on this curve because they either have a very high hype level or they have very high potential impact on industry. And you notice that all these data points have different colors. The light blue colors are moving faster along this curve. They're moving. They're going to be probably out in about 2 to 5 years. The dark blue circles are going to take about 5 to 10 years. And the sort of the yield signs, the orange ones, are going to take about over 10 years. So when you see this kind of analysis of the market, and each one of those technologies, by the way, Gartner has done a full study on, you can kind of tell there are certain things you probably don't want to do if you're going to be a startup, if you want to have an exit in 3 years or 5 years. There are probably other things that you want to do if you want to be strategic, and so on and so forth. So you look at this stuff. We've looked at these things. In the ascending part of the curve, we've looked at location-aware applications, predictive analytics. We've looked at biometric authentication, public virtual worlds in the trough. Sliding into the trough, we've looked at gesture recognition, mesh network sensor, microblogging, which is tweeting, and video telepresence. Right at the peak right now are media tablets. That's iPads, the BlackPad, the coming Cisco CS slate. Augmented reality, we've looked at that this year at CES, a Consumer Electronics Showcase. I'll show you an example of that. We've looked at speech-to-speech translation, really important. In San Francisco, Kaiser, we have over 100 languages in our patients. So speech-to-speech automatically is really, really important. Mobile robots, we've looked at those. We looked at computer-brain interface, which is really interesting, where you wear essentially an EEG sensor, and you can control the computer by what you think. Stuff that you wouldn't have seen, wouldn't even have thought of in science fiction 10 years ago is coming out. So what is our mission? We have three things. We innovate. So we identify, assess, and introduce innovative technologies that positively impact quality, service, and costs. We cultivate. So we use our tools and research and resources to encourage innovation. And finally, we connect. So we advise innovators, and we try to connect them, because in a large organization, it's amazing how many times somebody comes up with an idea, and they think that they're the only people that ever thought of it, which is really interesting. And then we just heard from 20 other people that did the same thing. So it's good to connect those guys and get some sort of synergy, because otherwise there's a lot of stuff going on that's probably redundant, and that's not very efficient for innovation. So here's an interesting thing. It's 5 days since the last paradigm shift. I mean, it's time to innovate again. Okay. Some areas of focus in 2010 and probably transitioning in 2011, we want to transform the care model. That includes virtual healthcare, that's telehealth, mobile health, next generation hospital, analytics. As Steve mentioned, Kaiser was a pioneer in the medical record. We bought Epic, which is our vendor, in 2003. We just finished the last installation about a couple of months ago. It took 7 years. 7 years. 9 million patients, 7 years. Now that we've collected data for 7 years, we have about 1 terabyte of data a day. We have more data than the Library of Congress, probably the world's biggest patient database. Next step, what is the value in the data? Right? So that's analytics. And I think that's going to be the next step. Just an interesting point. Right now, there's a lot of federal money going to getting physicians to buy medical records, part of the ARRA Act, the HITECH Act. And when that's done, when physicians get through the grief of putting in medical records, they're going to think about what is the return on this medical record. So for them and for us, the next step is going to be analytics. The next section is actually the service component, which is transforming the health plan member experience. Personalization through computers, access, convenience, virtual, high touch, and empowerment. And just a thought about that. Today there's a lot of publicity or a lot of media about empowering the patient and having the patient drive care. What's not discussed is the other side of the coin, is how much responsibility is a patient willing to accept for driving care. That's never discussed, which is interesting, because that's the other part of the issue. If they're not willing to accept responsibility, the physician's not going to give up responsibility, because it's his or her license on the line. So I think that's a really interesting question, not a tech question. We publish research reports for internal use. Here's an example. 3 years ago, I looked at a medication dispensing kiosk. The question to us was, can we build a new medical office building without a pharmacy? A pharmacy is very expensive. Can we just put in a kiosk? Stock the kiosk. You finish seeing a physician, you go to the kiosk, you sort of like an ATM, get your medication out. Well, on paper it looks good, but do you realize that even in a small clinic, you'd have to stock this thing with 5,000 medications, of which about 1,500 would have to go back on the shelf every day? That's a full-time pharmacist doing that. And then at the time that we analyzed this technology, California just passed a law saying that this kind of kiosk has to be situated next to a real pharmacy, which has sort of made the point moot. So the point with this was that we made a negative recommendation, or just let's watch it for now. So the question is, people ask, how successful are you with your innovation group? And that's really a very fair question, but it's the wrong question. The question is what is our value? And actually, there's more value through failure, if you think about it. We find failures in R&D, not in deployment. That's less costly, less risk, less disruptive, and we avoid sort of costly pilots. And of course, Babe Ruth said, every strike brings me closer to the next home run. That's very important. And he struck out a lot. What is telehealth? That's one of our initiatives last couple of years. It's a delivery of healthcare at a distance. In 2003, we had a visioning conference with top leaders from Kaiser to try to figure out what does healthcare look like in 2015. And we figured out that essentially the patient is at the center of care. So you see all the stuff around the patient, home as the hub of care, seamless and secure transitions, integrated and leverage medical records, customized care, all this kind of stuff. What does it take, to have this consistent care everywhere you touch the system? It takes a medical record, period. It needs the same information base. You have to have the same, so you get the same quality every time you touch the system, whether you're talking to your PT or your pharmacist or your doctor, whether you're walking into the clinic or you just called in or whatever. You need a foundation like that. And it's interesting today, most physicians in the United States do not have that. And that's been a big stumbling block, but very understandable because the value is not for the practice. Many times the value is for other parties. And so hopefully that'll change, but there's a lot of opportunity in that area. So we started this telehealth working group in 2007. We looked at the state of telehealth both inside and outside Kaiser to develop a strategy. Why is telehealth important? And there's a sort of variety of ages in this room. Who's a baby boomer? No, I shouldn't ask you. Okay. Demand is up. Were you born between 1946 and 1964? That's the post-war generation. That generation, 78 million people, are going to have diabetes, congestive heart failure, hypertension, chronic obesity, depression, all kinds of chronic conditions that actually cause a lot of resource utilization. Supply is down. Where's your physician born between 1946 and 1964? Like I mentioned, you may not be able to find a physician. Care model has the wrong focus. Do you have a 19th century care model? If you look back in the history of medicine literature, it's really interesting. A lot of the same questions that were asked today were asked in the 19th century. Care is too expensive. Fee-for-service is too expensive. The common man cannot afford health care. Same issues today. Costs are unaffordable. Do you have a 19th century business model? Do you have as somebody once said, do you have a sick care model, not a health care model? So what is healthcare tomorrow? One of the things we're thinking about, demand is up. Okay, we use remote patient monitoring to increase the data flow, increase capacity and productivity of our physicians. Supply is down. Can you use evidence-based rules to expand the workforce? Can other people do what the physician does and move all the way down the ladder, all the way down to the patient? Care model has the wrong focus. Earlier intervention improves quality and reduces crisis demand. Costs are unaffordable. Out-of-facility care reduces costs. So these are some of the issues that people will have to think really hard about in the next coming years. But there's always the skeptic. Right? I like the way of practice. My older patients would be too confused. Who'd be directing the care? Who else is doing it? Better outcomes been proven? Do I have to review all the data? That's an issue. There's a lot of data coming in, more and more in the future. And how do I get that stuff into my EMR anyway, in my electronic medical record? Here's an example of technology in telehealth. It's the Intel Health Guide. It's basically a home router it's essentially a touchscreen PC with a webcam. And it can collect things wirelessly like blood pressure and glucose and so on, send it straight to your provider, can alert the patient about dangerous things. Here's another one from a company in the UK. It's mobile, has a broadband card in it. But you think about this kind of stuff, you got the hubs in the home, you got the collecting devices, the biometric devices. That hub could actually be a mobile phone, and we've seen a lot of companies doing that, using a mobile phone as a data collector. We've also looked at other technologies like virtual reality. We had a company build us a virtual Kaiser Permanente hospital ward, and we trained our nurses in it using different scenarios that are hard to duplicate in real life. And it actually turned out really well. People do different things when they have an avatar in front of them. I don't know if you guys do Second Life, but if you have an avatar, you tend to be less maybe hesitant to speak up, to interact. So very interesting dynamics. One technology we've passed on to production is the hospital Courier robot. The robot is actually just the sort of the thing in front and sort of the Roomba device at the bottom. The whole cart actually is an existing hospital cart. So it's a harness. So you put the cart in there, and it does, it runs every hour. And the thing about this technology is interesting. The closer you get to clinical care, the harder it is to adopt the technology. This technology is doesn't have anything to do with medical care. Easy to diffuse this technology, easier to diffuse. cost savings in production. Digital pathology. I put this in here because in the future, a lot of our new tests are going to generate data that's 1 to 2 or maybe higher orders of magnitude larger than even radiology images. And you think about a slide, a digital slide. Many systems capture not just one focal plane, but as you turn the focus knob and you go through the slide, there are many focal planes. So some of these systems capture many focal planes. That's an exponential. That's a geometric increase in the size of the file. And these are all high-resolution files. There are also systems that will go through all these focal planes, all these slices, and use image pattern recognition to find cancer, to find all kinds of other things. So you're running all that kind of stuff. It's very computationally intensive and very storage intensive. And then, of course, it brings up issues of, do we need to store it? Right now, we store all our path specimens in Livermore. It's just we store it forever, but they're encased in wax blocks. But can this substitute for it? We're not there yet in terms of regulation. Hospital mobile PCs. You probably recognize the iPad. The thing on the right is a new Cisco CS slate that's coming out. There's various other things. Very active area of interest right now. Mostly so that people can do the charting and do their medical information exchange without having to be tied into one of those bigger things or to a desktop. We also looked at biometric facial recognition, which is very interesting. This is a company that does a topological map of your face. It measures the distances between the landmarks in your face, like your eyes, your nose, and so on. And it's constant biometric. So you're standing in front of the webcam. If you walk away, it'll shut down the machine. No other biometric does that. So very interesting because, physicians, when they see a typical patient schedule, they're logging on and off the computer 70 times, 80 times a day. Not only that, let's say they're in office, they have 3 or 4 applications running, and then the patient walks in, exam room. So they have to log out, theoretically, of all the applications they were in, so that you're HIPAA compliant, you're secure. You walk into the exam room, then you bring up all the applications up again, try to find out where you were. That takes time. You enter the password and everything else. Patient's done, you walk out, you got to log all, So it's a very cumbersome process. This system recognizes your face, brings up the applications the way you left it. It's server-driven. And one of the things we're looking at is, can you combine this with a virtual roaming desktop? For you guys who are in IT, that means that your desktop is in the server. So wherever you walk, wherever you go in your hospital, you walk up to a machine that has a webcam, recognizes your face, brings up all your applications the way you left it. That's cool. You don't have to carry a mobile device, right? Just your iPhone. So. Clinical gaming. This is a Nintendo Wii project we did. It's an 8-year-old girl who had cerebral palsy, very spastic on her left side, and she didn't want to do any more physical therapy because it hurts. So we brought her into our innovation center and gave her the Wii. And before we knew it, we got her into boxing. And we told her that her opponent was her brother, so she's going like this. So the outcome of that was that an hour and a half later, she's sweating, and she's punching away, and she doesn't want to stop. But see, she's not doing physical therapy. She's doing a game. So the whole idea of incentivizing people to do healthy things using non-medical incentives is a very interesting area. Very interesting area. Auto hand washing. Hand washing is a big deal in hospitals because it's a big source of iatrogenic or hospital-based infections. So the statistics are, if you shake hands, if you're in a hospital, ever in a hospital one day, you shake hands with your doctor or your surgeon, there's a 49% chance that you're shaking hands with their last patient because they didn't wash their hands. And so that's a scary thought. So this machine has got 2 holes in it, and it's supposed to be, you stick your hands in, it's supposed to be like a spa-like experience. It's so pleasant that you don't ever want to take your hands out. 10 to 20 seconds, you're sterile for 6 hours. It's really, really interesting. There's new technologies in this area that actually, there's a guy here in Berkeley, there's a professor in Berkeley that's actually working on it. It's called cold plasma. It's generating plasma that's cold, not hot, with electricity. And so that, you can sterilize your hands by just putting it into this plasma field for 2 seconds. That's interesting. So you can walk through a plasma field into your patient's room. I think that's very, very interesting. So we're looking at all kinds of things to try to increase hand washing. Digital signage for wayfinding, education, portal, broadcasting. Augmented reality. We saw that at Consumer Electronics Showcase. This is where, here's a pair of glasses. You actually can't see through it. It's got two little cameras on the side so you can see kind of like what you would have seen. But it's got the earbuds. And what you see is a screen that's got reality overlaid with computer graphics. So what are some of the applications? Let's say you walk into a hospital. You've never been there, so you're wondering, how do you get to my doctor's office? You put in your augmented reality glasses, and then it tells you, just follow the things on the floor, the arrows, so you just kind of follow the arrows. Because you see it in your glasses. Or you see a sign in the hospital that's in English, but you speak Chinese. It does the OCR thing, it recognizes the text, and it translates to you in your language. We actually have a device that does it in our Innovation Center. XR gaming, very interesting. You're actually playing a video game, but you're actually out in physical reality. You're running around buildings and stuff. You see people pop up, you shoot them, whatever. That's very, very interesting. Video conferencing, auto translation. The best application, you're at a party, right? And you see somebody, and you don't recognize you. They kind of look familiar, but you don't know who they are. So this class is like, okay, facial recognition number 1, right? Goes to your database. 2 seconds later, oh, you never want to talk to this person again. Okay, I'm going to go to sleep. That is cool. How do we cultivate innovation? Our Garfield Innovation Center, Stefan was there, and a couple of you guys have been there, opened its doors in 2006, 37,000 square feet just down the road, next to Oakland Airport. Full-scale medical surgical mock-up, labor and delivery room, operating room, ED, home environment, IT lab. This is our medical surgical ward, a template ward. So we have optimized the heck out of this ward before we build it into a new hospital. And that makes a lot of sense. We used to, and the tradition still is in most health plans and most hospitals, is they build every hospital on the site, one by one. That's very expensive. So what you do is you create a ward that you just run your nurses through it, your doctors through it, your patients through it, just make it ideal, and then build it. And this is what we've been doing. This is very, very effective. Saves a lot of money. Here's our operating room of the future. We've been designing this room to accommodate different specialties, different kinds of workflows, and this is part of our Garfield Center. Our telehealth home environment is actually an IKEA home environment, as you notice. You might see the same furniture you have in your house. We do space design, workflow, technology demos, training and simulation. We've had over 25,000 visitors from 35 countries, and you're all welcome to tour if you like. Just give me a call or send me an email. And we have 4 innovation zones. We have prototyping space, the hospital, the clinic, and the home environment. We have an innovation fund for technology, which is an internal fund, multi-million-dollar fund, to encourage any employee to apply. The only catch is they have to prove their idea within 6 to 12 months. So either it's a good idea or a bad idea. We've had 250 proposals, 40 funded, 10 in production, which is really good if you think about it, in terms of VC, venture capital. We connect innovators to each other through many different means. We've also tried to eat our own dog food. We try to use the latest technology tools. We've done technology demos, tons of stuff. You can look at some of the stuff we've done. We continue to do that. We had an interesting technology demo on body sensors. There are clothes that you can wear that sense your vital signs and your activity level and things like that. So you can imagine in the future, your home, your clothes, your furniture, everything could be reporting data on you and what you're doing just for your medical care. The problem is, what do you do with the data? And who do you want to share it with? We have an Innovation Hunter program. These are folks that connect the regions that we have, the 8 regions, with the national innovation group. And we have a social networking tool for innovators where people can share ideas. Like I mentioned, part of the problem is people don't know each other, who's working on what. So we have a social networking tool based on a platform called Jive. And it grew organically. We started in 2008 with 150 invitees. Without publicity, it grew to 1,500 users by 3 months. And today it's over 25,000 innovators online. That's powerful. That's 25,000 out of our 170,000 employees. And finally, we've had a lot of media. If you read, once in a while we show up in the media. We won the award for Fast Company 2010 Most Innovative Companies. I've had the privilege of talking to the BBC. A lot of countries overseas are very interested in what Kaiser's doing because we're kind of like them. We're like an integrated care delivery system. We're about the same size in terms of number of patients. So we talked to a lot of interest from around the world on how do you number one, do medical records. Number two, how do you manage chronic conditions? And with that, that's the end of my talk. It's 12:50, so welcome any questions.
Thank you. Before questions, so that you can be an official CITRIS speaker.
Awesome. Thank you.
Do we have any questions for Dr. Chow?
Yes.
I notice of some of your data point, especially with interactive patient care, it showed that it's about 3 to 5 years or 3 to 5 years down the road. But do you think some of those data points could actually be expedited because of, for example, now the announcement of Google TV, for example?
Right.
This kind of ideas could actually expedite the acceptance of this type of technologies.
Right. I think the hype cycle, if you look at that curve, one of the things it doesn't show is what's behind the curve. And for instance, in telehealth, a big part of the reason you see a lot of dark blue dots for the telehealth hype cycle is that Medicare, Medicaid is very slow to reimburse for it. That's a big factor because if the doctor doesn't get paid for doing that, they're not going to do it, period. And so I think those factors are things that are game changers. So I think if there are changes in the industry that will affect that, they update those curves once a year at least, if not more. So I think that would change it. Yeah. Yes.
Other questions?
Hello, my name is Saul Rosenberg. I used to work at Kaiser as a psychologist and as a clinical researcher. 20 years ago, Kaiser was a leader in behavioral health, and they still are. What's curious is that neither Kaiser nor anyone else has really developed a comprehensive approach to behavioral health and primary care and mental and substance abuse disorders. I wonder if there's anything going on in that area at Kaiser that you could tell me about, and I'm also particularly interested in predictive analytics and your experience with Archimedes and how predictive analytics might be able to be applied to behavioral and mental health.
Great, thank you. Yes, I think there are some, but as you mentioned, there are some early efforts and embryonic efforts. There are projects to do some mental health support groups and even counseling online and virtually. We've had some innovation projects doing that with some success. The other issue about Archimedes, I guess I should mention to the audience, Archimedes is a mathematical model that was developed at Kaiser over many decades by Dr. David Eddy and other folks. Very comprehensive, very complicated model that models healthcare from the macroeconomic level all the way down to the molecular level. And I think their claim to fame is that they've been able to predict the results of clinical trials before people even run those trials for diabetes and things like that. So can you imagine the usefulness of that? You can pick and choose the trials that are most likely to be successful. So in terms of personalized care, they've been trying to use Archimedes recently in Hawaii to help with counseling patients. So they use the Archimedes engine. So when you go in to see a doctor, the doctor will consult Archimedes. So it'll look at all your factors, your history and everything, and predict what are the things that you should do for yourself, particularly you, that'll help you improve your care the most. And I think they've run that pilot, and it's sort of got mixed results. I think it's still hard for physicians to understand how to use something like that, especially something that appears as a black box. I think black box technologies are really difficult in healthcare because if you make decisions based on those things that you don't understand and something goes wrong, then you're in deep trouble, because you can't justify it. It's not a peer-reviewed. So I think there has to be a level of transparency into how it makes that decision. If that's possible, and if the peer group agrees that that's the best practice, then you're protected in some way. But making those clinical decisions is very difficult when doctors are very much driven by data, evidence-based, and traditionally it's 5 to 7 years of clinical trials, and for technology that's an eternity. When you talk about technology, you can't wait 5 years. Things will be all different. So the dissonance, the conflict between the two to reconcile technology, the pace of technology with healthcare, which is very risk averse, that's always going to happen. But I think it's an interesting technology. Yeah. Yes.
Thanks for a very exciting survey. I have a question about the way in which you make new technology available and known to people. And I'm thinking about a particular example. About 2 or 3 years ago, I heard that there are going to be centers, stroke super care centers being set up. And I tried to find out about 2 years ago where they would be and what was going to happen. And then about 6 months ago, I called again. I couldn't find out from anybody that I was calling where they might be. And then about a month ago, my neighbor, or maybe it was a few weeks ago, during the first Cal football game, my neighbor had a stroke. Wow. And so I convinced his people who were staying in his house next door that maybe we should call and try to do something. And eventually talked to a physician at Richmond, Kaiser, and they got a big fire truck and also American medical assistance. Right. I tried to find out later why the fire truck was there, but then that's another topic. The man, I said, okay, where's the local best place for a stroke? And he said, well, we're closest to Richmond. So he got taken to Richmond. I heard Vallejo mentioned during there, and later I found out that after he sat on the weekend and didn't have nothing done, no blood thinners, nothing, just watched while he had his stroke over the weekend. He did go out to Vallejo for rehabilitation, and now he's got a lot of people coming by to help him rehabilitate. But look, the information needs to be where you need it and when you need it, and how do you do it? And this must be something that you've thought about, but please tell me where I can find out. I was a member of Kaiser from about 1942 to about 1948, and then again in 1976. I'm not at the present, and maybe we'll go back sometime. It would be nice. But where can I find out crucial information? Because you've got to do it fast for strokes, just like you've got to do it fast for cardiovascular events.
Right.
Thank you.
Right. It's interesting. I think that's actually one of the good use cases for teleconsultation. Actually, we're looking at that, telestroke. Because as you say, there's only a 3-hour window before you have to stop giving the TPA, which is the medication to stop strokes. Because beyond that, the statistics are it's dangerous. So if you miss that 3-hour window, you're not going to get anything. You just kind of have to sit there. But if you can get within the 3-hour window, to give that TPA, you have to get a neurologist to certify. As a primary care physician or ED physician, emergency department physician, you actually don't have the ability to do that, at least on our system. You don't have the expertise. So the neurologist has to be consulted, but who knows where the neurologist is on the weekend, right? They're usually not in the ER. So the question of how do you bring them into the ER on a time urgent basis to look at the patient, see how they're walking, talk to them, and tell the ED doc, oh, go ahead and give TPA, or don't give TPA, it's not a stroke. I think that's one of the clear use cases for telehealth. And we are actually running some pilots in that so that we can actually, in Northern California, be able to broadcast an on-call neurologist to any ED that's a reception point for a patient. But I think what's really interesting is that some of the ambulance companies are getting to the act. They're starting to install cameras and things like that inside the ambulance so that you can save time. And before you get, you only have 3 hours. So if you start having signs of a stroke at 5 p.m., you better get to somebody by 8 p.m. or they're not going to give you a TPA. If you get TPA, you get very good results. But so there's a time element. So in the ambulance, they're looking at actually providing the access to the consultant, which is amazing. So moving ambulance, you can see, talk to the patient, etc. But I think for telehealth in general, the other use cases are not as clear. If you have a good disease management program, the difference between that and telehealth is not that much. So, as I said, it takes a while for people to get up to the slope of enlightenment to find out what exactly you should use these things for. But yeah, so I could try to find out for you. I'm not aware of anything like a super stroke center, but I could certainly try to find out what's going on with stroke. Yeah.
Dr. Chow, thank you very much.
You're welcome.
Thank you very much for being here today. Remember, I for Energy, Friday at noon, every Friday at noon, Research Exchange every Wednesday at noon. Thanks again for coming.
Okay, good.